Good evening, everyone. My name is Paul Frischman, and I'm privileged to be the CEO here at the Galbert Family Miami Beach JCC on the Simpkins Family Campus. And on behalf of our entire board and professional leadership here, I thank you for joining us tonight for this very, very relevant and extremely important informational program that we have tonight. We are so extremely proud of how our Miami Beach JCC has continued to make a tremendous positive impact within the community during this most challenging time. Critical services for close to 5,000 individuals that we serve, camp programs, virtual schooling, food drives, COVID antibody blood drives, vaccine outreach, so many virtual options, and also safe in-person opportunities for learning, aquatics, health and wellness, plus recreation. Throughout the JCC serving this community for the past 17 months, safety and strong COVID protocols has always been our highest priority. We're also so very proud of our partnerships, and tonight is a perfect example. Working closely with us tonight is our sister JCCs, the Posnack JCC in South Broward, the Alper JCC in Kendall, and the Michael Ann Russell JCC in North Miami Beach. And leaning on the medical expertise of the Nicklaus Children's Hospital to bring us much needed information. Special thanks to NCH's CEO, Matt Love, Deborah Wasserman, Yoli Perez, Shari Dabrowski, and the entire Nicklaus team. And of course, our esteemed panel of expert doctors will be moderated by our very own JCC member, Dr. Chad Perlyn. Finally, our JCC leadership, they are led by Karen Sepsenwall, Natalie Usum, Jenny Mermelstein, Dietrich Delmas, and Mauricio Perez. Our goal tonight with this program is to help educate you. Also to make sure that you understand medical facts in regards to COVID-19 and how it affects your children and your families as we head back to school. Tonight, close to 1,200 families are tuned in for this virtual information. That is by far the largest program that we've had online to date. Right now, it's my pleasure to introduce another one of our JCC members, the esteemed mayor of Miami Beach, Mr. Dan Gelber, for some opening remarks.
Thank you very much, Paul. And I want to thank our own JCC and all of the JCCs who during this pandemic have really worked very, very hard to keep a sense of community in our areas, to provide a positive environment for our children. Really, we are here and in so many other places fortunate to have JCCs who have able leadership like Paul and his staff. And to the parents who are on this webinar, I know you're excited to get your kids back to school, and I want you to know, as a parent who's sending a high school senior back to school, I feel a lot of the confusion that's out there. The marketplace is so full of so many positions right now, so many arguments, so much information is out there. And it's easy, in fact, to find an approach that might be the easiest road because there's going to be somebody who's going to tell you just what you want to hear. It's easy to find support for a political approach. In our city, we have followed a very simple rule: follow the science, follow the medicine. Find experts who don't have an agenda but simply want to tell you how to address this. In my city of Miami Beach, one of the guys I play basketball with is Dr. Ari Cement at Mount Sinai. He early on, before even a single case had happened in Florida, called me up and said, "You better get ready. You better gird the city for this. This is going to be a lot worse than people think, and you're going to have to start thinking about ways to change how we do things." And I trusted him and a lot of the staff at Mount Sinai, and we did. And we followed the recommendations. We followed our doctor's orders, even when the medicine was hard to swallow. My city, by the way, of the 10 biggest cities in Dade County, has by far the best results on the major metrics, despite the fact that we have a pretty elderly population here. We still perform better than every other large city, essentially, I think, because we follow the medicine and we listen to doctors like Dr. Cement. So tonight, parents, you are doing your job, and you're doing it well because you're going to listen to some of the great minds in this area, not people with an agenda, but other than to just tell you the best science and medicine they know. And they'll answer your questions and they'll give you a chance to figure out, what you're comfortable with. But it's so important that you stay informed, and it's so important that you have access to the experts who know. And you're doing your job right now. And I want to thank you and the JCC for helping us all do it. So have a great session and have a great school year. And I hope all your kids do wonderful things this year and that they're health and safety, God willing. Thank you all.
Well, good evening. And thank you so much, Paul and Mr. Mayor, for the warm welcome. On behalf of Mr. Matt Love, our health system CEO, and the entire team at Nicklaus Children's, we are so honored to be here tonight to serve our community at such an important time. Our hospital was founded in 1950, and shortly thereafter, as polio engulfed the nation, we became the regional treatment center for caring for children affected by that virus. Tonight, we are so proud to be able to continue that long tradition of providing world-class pediatric care. Over the last few weeks together, we've talked to many families, and we've heard their concerns and listened to their questions. And tonight, we'll share those with you as we navigate together this new surge of COVID-19. Before I begin, allow me to introduce myself and the panel that's here with us tonight. I'm Dr. Chad Perlyn, the president of Nicklaus Children's Pediatric Specialists. Tonight we have Dr. Maria Franco, a pediatric pulmonologist or breathing and lung specialist. Dr. Marcelo Laufer, an infectious disease specialist in pediatrics. Dr. Victoria Milla, the lead pediatrician in our primary care centers. And Dr. Mark Mestre, who's an expert in pediatric hospitalist medicine. As you notice, I'm not wearing a mask right now. I'm going to ask the panelists to remove their masks as well. Please note, and I'll repeat this later in the session, that we have all been vaccinated and we're PCR COVID tested this afternoon. Everyone else in the room is wearing masks, so thank you. Our goal tonight is to share what we know and what we don't know about COVID-19, and to do so in a way that inspires prudence, not panic. We're all parents, and we all have the same concerns and are grappling with many of the same decisions that you are. All of us want our children to stay happy and healthy as the school year begins. But tonight, not as parents, but as pediatric experts, we're going to share with you, through your questions, our experience with COVID over the last 18 months, both locally, as well as sharing the national consensus from scientific and pediatric societies. And so with that, let's begin. Thank you all so much for being here tonight. Dr. Mestre, why don't you start by telling us, what are we seeing locally in South Florida? We've heard a lot about Florida, but tell us about Miami in particular and this area.
Thank you, Dr. Perlyn. I do want to share this chart that we brought and just kind of go over some of the statistics that we're seeing in the area, more specifically what we're seeing at Nicklaus Children's Hospital. During the beginning of the pandemic, we've all heard the story that children weren't very affected by the COVID-19 infection. At that time, children were only making up about 2% of the infections across the country. And as time has gone on across the country, we have seen the increase in pediatric infections increase to about 14% of the infections that we're seeing on a weekly basis. And that's shown here in terms of what we're seeing in regards to our visits and our hospitalizations. We're definitely seeing an increase in visits to our emergency departments and our urgent care centers across the country, across the city. And that's translated into increased admissions into our hospital and requiring hospitalizations for children. As you may have heard in the news, children's hospitalizations are at an all-time high, but thankfully, those children typically do very well. What we see here in our chart is that back in July of 2020 was our peak prior to what we're seeing now. That's when we were seeing children being hospitalized. You can see in the month of July, we had 118 patients hospitalized at Nicklaus Children's. Starting in about mid-July, we started seeing an uptick in terms of the patients that were coming to our emergency departments and that were becoming positive for COVID-19 and translated to increased hospitalizations for children. You can see in the month of July, we saw 73 patients that were admitted. And now, midway through August, we're already at 80 patients. As you can see, if we continue at this pace, we will see many more patients that we saw in our peak in July of 2020. Thankfully, as I mentioned before, children do relatively well with the vaccine, with the virus, especially if they're vaccinated. We have not seen any patients, we saw one patient that was admitted to the hospital that was vaccinated, but that patient was immunosuppressed. All other patients were not vaccinated. So many of those that were eligible for the vaccine and received the vaccine did not require hospitalization. And as you see here, currently our positivity rate, just to give you an example, in June when we were at one of our lowest rates, we were about 1% to 2%. Our current positivity rate is 7-day positivity rates at 15.7%. So 15.7% of our patients that are tested return as positive. On a good note, we're hoping that we're reaching a peak or a plateau. As you can see here, we've reached a steady state, but again, with school starting soon, we're going to see if that changes or not. This is one of our lowest positivity rates that we had yesterday, was 58 positive tests across all our centers. And in regards to what we're seeing for those patients that are hospitalized over the last 2 weeks, we can see most of our positive tests are in children from 0 to 11. Again, that population that cannot be vaccinated. 75% of the tests that we have been that are positive are in that population, and 25% are in the 12 and above. But in retrospect and looking at our hospitalizations during that time, we are seeing a greater percentage of the patients in terms of hospitalizations for those 12 and above. That tends to be our population that tends to be at a little bit more risk, especially those who may be obese or overweight. So 46% of that population is what's hospitalized. You would think it would be equal to the 25%, but actually they have a greater risk for hospitalization. So those are the trends we're seeing here locally. Nationally, are seeing similar trends, especially in the South, where we're seeing an increase in hospitalizations. And the percent of hospitalizations that we're seeing, risk of somebody being hospitalized if they have a COVID infection is about 1%. So 1 out of 100 children that have a COVID-19 infection tend to be hospitalized.
Just to summarize, those 1 in 100 children who are over the age of 12 with vaccine, we've only seen one child, is that correct, who has been vaccinated and hospitalized?
That's exactly right. And that patient was immunosuppressed. So those patients are going to be at even higher risk. So those patients, even those that are under 12 that we've seen that have been hospitalized, many of those patients obviously cannot, or all those patients cannot be vaccinated, but many of their families also have not been vaccinated as well, which puts them at increased risk.
Great, thank you so much. Dr. Franco, by now we've all heard of the Delta variant. Can you tell us a bit more about it? What makes the Delta variant so different, and how does it affect children?
Fascinating. This virus has shown to all of us that is capable of mutating pretty fast. So what is the mutation? So let's think about the virus, and the spike is where was the mutation coming from. So that spike actually had 3 mutations that made the virus more effective in launching to the cell than in the human cell, and penetrate the human cell in order to become the human cell their factory to produce more virus. So it became extremely easy to produce a lot of viruses, and that implies that it was easier for them to infect more people. The initial virus, probably when you get in contact with somebody, they was able to infect 2 or 3. Now the average is to infect 6 people. So that's what it became like a wildfire a little bit into this. So is the capability of these virus that when mutated to become so effective and so ingenious to actually get into the cell and produce many more. So that is the risk for the children, obviously, because obviously there are a couple of things that are being happening. One of them is that the behavior of the people has changed, and the behavior of the virus has changed. So the behavior of the people is that we were like more open. We took the vaccine. Many people felt like comfortable, that things were getting, more normalized. We're trying to normalize. So we were socializing even more. We were able to go out and be in restaurants and other things, and people start going to have a normal life. And that is the behavioral part. And the virus became behaviorally also very bad in the sense of more numbers. So it was easier for when the Delta came, just found the perfect ground because you had more people, less mask, more open, and the children start getting more exposed. In the past, we were having the children were not going, few were going to school, they were having the mask. They were, last year, we were much more inside in our own homes, which was not ideal either. But then we opened it up and the Delta came in the moment that's what it became so more for children. And it was more obvious to see them in children.
And so besides it being more infectious, as you're describing, there's evidence supporting that. Is there evidence suggesting that it's physically more dangerous to children? Does it do more harm to children or no?
No, they have not shown that. The dangerous part is because they're infected more in the numbers, but not in the severity of the disease. We have not seen they are more severe. We have not seen that is making more like our mortality rate or the admission to the hospitals. We're seeing very similar than the other ones. It's just making the peak more dramatic because of their more and more. And we have seen that the parents who decided not to get vaccinated, we are seeing the children were getting infected are the families, that the whole family, because now the virus was very easy to jump into everybody else. So they get the whole family together infected. So it was easier to jump to one to the other.
Well, great to know that so far the evidence does not suggest that it's more dangerous.
Correct.
Dr. Milla, as our lead pediatrician in the primary care centers at Nicklaus Children's, you certainly know a lot about pediatric vaccines. Can you tell us about the mRNA vaccine? We know there's so much anxiety across the community. Many parents are concerned about its quote unquote newness. Can you talk about that and discuss some of those things so parents understand really the history behind the vaccine?
Sure. So mRNA technology is not new. It's something that's been around for over 20 years and has been studied in viruses such as the flu and the Zika virus. The difference between the Moderna vaccine and the Pfizer vaccine versus the Johnson & Johnson vaccine is the way that the information is delivered to the cell. So Moderna and Pfizer both use the mRNA, and that's the messenger, and that's what the cells receive. And then the Johnson & Johnson vaccine uses a disabled virus. So that's the difference really between the two.
Any idea when we're going to see it for kids under 12?
No, so the exact date of when that is going to occur, we don't have. What we do know is that Pfizer, which is the only vaccine right now that can be given to children under the age of 18, is going to be presenting their data for children between the ages of 5 and 11, sometime in September or October. And if the safety and efficacy is similar to that in adults or in older children, then we should see that shortly thereafter.
Great, thank you.
Mm-hmm.
I know lots of parents are anxiously awaiting that news. Dr. Laufer, let me turn to you as our pediatric infectious disease expert. Lots of questions about the vaccine safety, side effects, things such as infertility in adolescents, myocarditis or inflammation of the heart, severe reactions. What have you seen over the last 18 months? And what have you seen nationally with you and your colleagues?
The vaccine is extremely safe. I mean, we started being vaccinated ourselves, the doctors, you, me, Dr. Franco, back in December, when we had a trial on 30,000 people. By now, millions of people have gotten the vaccine. When you're gonna see bad reactions from vaccine, you see it right away in the first 2 months, 3 months, 4 months. We are now much ahead of that. What are we seeing? What are we seeing in pediatrics? We're seeing the same thing that the adults are seeing, the little bit of an arm pain, a little bit of low-grade fever. We have not seen the anaphylactic reaction that was so expected in the beginning. And regarding the myocarditis is an entity which has inflammation of the heart. COVID itself is a known cause of myocarditis. There are papers that say that up to 1 in 100 young adults who have COVID are going to end up having some degree of myocarditis. whether they know it or they don't. The rate of cases of myocarditis is 1 in 20,000. So out of 20,000 children who will get the COVID vaccine, 1 may have inflammation of the heart. What have we seen it? We've seen a very small number of patients, under 10, who had a mild case of myocarditis with minimal need to being in the hospital, treated with anti-inflammatories such as regular ibuprofen or naproxen, which is morphine or Aleve, and without any type of sequela. Nothing about infertility rate, nothing about causing problems with fertility. There's no whatsoever any relationship between the vaccine and the possibility of that person not being able to have children in the future.
That's great to know, because that's such a concern for so many families. What would you say to families who may want to get their child vaccinated and they understand that there have now been millions of doses given around the world, but suggest that there's just not enough time to know everything and what may happen in 2 years or 3 years or 10 years? How would you talk with those families if they were in your office asking that question?
Well, I do have that conversation on a daily basis. What I told them is, number one, no one is going to be safe until everyone is safe. So there's no way that we're going to be safe until there's no more infections or reduced number of infections in our population. I then tell them, look at the number of patients that had gotten the vaccine. It's a tremendous amount of patients. We do have a system in the United States called VAERS, in which every time that we do see a minimal or severe or moderate type of reaction, we have the obligation to tell the government this is what happened with this patient. Actually, Dr. Mestre is the one who is in charge of reporting on each of them. I would also tell them that we, the physicians, were the first one who had the privilege. I called it a privilege because most of us were given the privilege of getting the vaccine early. And we got it, and not only we got it, we encourage our colleagues to get it, we encourage our spouses to get it, we encourage our children to get it. So we went in stages. You know, we first started with adults, and then we went to children, which is sort of different than what's done in most vaccines. So children were given the opportunity to have the experience of millions of people who had gotten the vaccine in a very safe way.
You know, I had the opportunity not long ago to hear you talking to a family. You shared the polio story, speaking of polio, and you mentioned the number of children that unfortunately caught polio while their families were waiting for that same thing 50, 60 years ago to see if the polio vaccine was safe. And that certainly resonated with me. And I think many of us as before.
It took 5 years for us to achieve polio vaccination over 90% of the United States. So it's taking less time, even though we are a little bit disappointed with the numbers that it can be better, but it's much better than when we were starting with the polio vaccine. It's a natural reaction of society. Look, when the epidemic started, we locked down. And the reason for lockdown was to save people until we got the tools to save us. Now we do have the tools. And the tools are vaccines, education of our behavior. We were able to rebuild our infrastructure of hospitals in terms of PPE. We learned how to treat the patients. And now we have a very important segment of the population who's still vulnerable, who we have to defend. When I talk about it later, about how we want to do that. But we already did what we had to do, locking down so we can be at this stage. And now we have the tool. Now we have to use it. Vaccines in the refrigerators are not as good as vaccines in the arms.
Thank you so much. Dr. Mestre, we have a lot to talk about tonight, but I just want to touch base on it because you were one of the physicians who first reported to the CDC some of these very early concerns about myocarditis. Nicklaus Children's was involved in that very early on. Can you just briefly, I know Dr. Laufer mentioned it, but so families hear about this heart inflammation and just how rare it is and whether it's serious or whether it resolves?
Sure. It's definitely something that you could see in the rates that Dr. Laufer mentioned, very rarely in that 1 to 20,000 range after the second dose of the vaccine. After the first dose, it's in the range of 1 to 100, 120,000. So something that's definitely very rare, but could occur. The symptoms that we saw 10 patients, or we have seen 10 patients at the hospital that reported some form of myocarditis, which in fancy terms is just inflammation of the muscle of the heart. And what they typically present with is some sort of chest pain, sometimes some fever. Other than that, not many other symptoms. And those patients had come into the hospital and were tested for certain enzymes that are in the heart. And we then found out that they had this inflammation of the heart. Thankfully, the function of the heart remained normal. There wasn't any effects from that. They are followed by our cardiologists and our infectious disease teams after they leave the hospital, and typically have a course of 1 to 2 days in the hospital. And across the country, there have been similar cases that have been reported, about 1,000 of those cases. I spoke individually with the CDC and the VAERS, the Vaccine Adverse Events Repository, and we reported all those cases in full transparency. But I also like to speak to families in terms of saying those were 10 patients that we had hospitalized. Back to the graph that we've seen here, how many more patients were hospitalized than those 10? So when I have those conversations with families and saying, what are the risk benefits that we're discussing? The risk of being hospitalized, again, is that 1 in 100, as opposed to the risk of having myocarditis with the vaccine is 1 in 20,000. When you show those numbers, it makes sense in terms of moving forward and having the vaccine when available.
I think it's great for parents to understand that. Thank you so much.
And in adults, not as common in pediatrics, but it may happen in pediatrics too. There are damages to the rhythm system of the heart that might require pacemaker placement for the rest of the life of the patient just caused by COVID. And that can be easily prevented with a vaccine.
Yeah, thank you.
It's 1.8 billion people being vaccinated. It's not in the hundreds, it's in a billion. I don't think we ever seen a massive vaccination in our lifetimes. And I hope we never see it again for other future pandemics. So people need to take in context that, yeah, it went fast, but not that fast. Actually, we act fast because we now have the technology. This is not 1930s. This is not 1950s. This is not 1960s. This is a completely different era, and we need to adapt to this because I don't think this is going to be the first time they're going to see this. 1.8 billion people have had vaccines.
That is a great point. Dr. Laufer, don't put your mic down. As the infectious disease specialist, you knew you were going to get some questions about masks tonight. Certainly something that is on everybody's mind. Lots of information flowing around. One study showing this, one study showing that. Tell us, in your professional expertise as a pediatric infectious disease specialist, national leader, why are masks important? And can you summarize some of the evidence in a way that parents can understand it?
The consensus among us is that masks do prevent infection in 2 ways. It's a source control, so the person who is infected will not be able to pass the virus to somebody else. And it's a barrier control in the fact that the person wearing the mask, being in contact with somebody who is shedding the virus, will be protected. There are different types of masks, and I don't want to go and talk about all of them. But the important thing is to have that form of a barrier. Maybe later we're going to discuss the type of mask, but what I want to concentrate now is on those 2 pies. If you look at those pies that are in the poster, the blue part is the children who are under the age of 12. Those are the children who they do not yet have the privilege of being vaccinated. The only line of defense that we have for them is behavioral mask. We have no other line of defense. So to me, I don't really, I do understand and I empathize with the parents and children who do not want to wear it. But remember, there is a light at the end of the tunnel. We all gonna get vaccinated eventually. And that eventually is a very short time term. So in the meantime, these few months that we have to protect our children, the best way to do it is through masks.
And so let me ask you another question that I know lots of families have been concerned about. Perhaps there's a child in school, maybe there's only 1 or 2 children who are wearing the masks. And we know the notion that masks act as barriers, and if everyone is wearing them, the protection. But if there's 1 or 2 children wearing the mask, would you advise parents to continue? And on what reason would you advise them to wear the mask?
I would still advise the parents to continue wearing the mask. There's no damage in wearing the mask, and there's always a gain of wearing the mask. And I would also work with that particular classroom, and I would work with the particular leaders, explaining, listen, this is what we're seeing. There is no reason to be just one child being vulnerable. Look at what the data says about the CDC, about vaccinated versus not vaccinated. The only line of protection that we have against unvaccinated children who are exposed to the COVID is mask. So yes, I would tell those parents to keep wearing those masks.
Thank you. I just want to mention to the audience, if you're joining us late, we're talking about masks. And of course, you see us not wearing masks now. Earlier at the beginning of the program, I mentioned that each of us is vaccinated and did have a PCR test this afternoon, specifically for this event. And we'll be putting on our masks shortly thereafter. So thank you for understanding that. Dr. Franco, Dr. Laufer mentioned types of masks. Lots of discussion about that, whether children should wear a K95 or a 3-ply cloth mask. Tell us, in your experience as a pediatric pulmonologist, what do you think we should be telling families about mask use? And also concerns that we've heard. We've heard about raised levels of CO2 or issues with speech and oral motor development or mental wellness. What's your thoughts and what does the evidence show on those things?
Actually, it's a very common question to get in pulmonology. You know, most of my patients have some respiratory issues. They have asthma, cystic fibrosis. They have other things that obviously respiratory problems. And so my advice always to the parents is, okay, so which one is the best mask? Answering part of it, Dr. Laufer. The one that the child would like to wear on, the one that he loves to have. So at the beginning I was saying, okay, you might need to buy several of them until they find one that they feel comfortable putting on and they will keep it on. And also tell them, please buy 7 of them because this is going to become the underwear of the face. Meaning you change your underwear, you put that into wash, and the next day you have to have a new one because you don't want to repeat the same one all the time. What I found beautiful about this is that children that come to my office, they want to keep their mask on. They don't want, when I try to ask them to take it off so I can see their mouth, I said, no. That they follow what the adults do. They actually do believe that the adults are there and they like what they have and they feel comfortable with. So they emulate the adults. So that's something we are always the shadow for the children. So if everybody wears a mask, they're going to feel comfortable about it. Now, the older ones, they are a little bit more, they want to see what they want to wear. Normally, we like them to wear, they can wear an N95, they can wear the disposable ones. The majority like the cloth ones. The majority actually do wear the normal cloth ones that they did. And the girls actually now make it in the combined that they look exactly what they're wearing off. So there are a lot of things that we can feel comfortable. There are very few that they are not tolerating the mask. And that's the ones that we ask them. No, there's some asthmatics that they are feeling shortness of breath and they get a panic attack. That are the exceptions. There are very few. Not because there is no evidence so far and so ever. There is not one single study that we have seen with good validity that show that the CO2 goes up, implies that you get intoxicated with your CO2 or decrease of oxygen level. We have not seen that at all. Imagine if that happens to surgeons who stay 12 hours doing surgery, everybody will be dying at that time. So we don't see that. In children, we don't see that in particular. I know you're going to ask me about it in the future, but I want to say it now. I do not specifically, personally, I don't like them to wear the mask when they're outside. We know outside is better. There is an increase that Miami, this area is too hot for children to be a mask and running around and sweating. Is not actually that we support in sports. And we hope that they have enough. I think the space in between them is the most important thing, but we don't support it to use them as well. They're doing the PE, specifically because it becomes a very iceberg. It's difficult to breathe with a mask, the heat and the humidity of Florida. So I don't think it's humanly possible. We will not do it. We will never ask them to do it.
Back in 2020, when we started with this pandemic, and we had shortage of testing, and we couldn't test every person admitted to the hospital. Nowadays, I don't know if you know, but when your child comes to be admitted to our facility, they are going to be tested for COVID-19. So we know exactly who is infected and who is not. But in the beginning, we didn't know. So we established in the hospital the universal masking for physicians, nurses, logistic personnel, parents, and patients. And I investigated every single of the exposure of a healthcare worker to a person who was positive, or two healthcare workers together. So what was the risk factor that increased infection? The amount of time that they spent together and the mask. If both of them were wearing a mask, the risk of infection was less than 1%.
So interesting. Thank you. And so I just want to summarize the mask issue and feel free to join in. So it sounds like for the older children, a KN95, not necessarily an N95, a surgical a respirator, that type mask, but a KN95 if they were comfortable with it, or even a 3-ply surgical mask, which is what most of us have worn throughout the entire pandemic. I myself, most of the time, that's been the mask that I've worn. And thank goodness I've remained COVID-free. And for the little ones, your advice is any mask that they'll wear is more important than trying to find the right mask.
Exactly. And the important thing is they're masks that we have been tested and we know they actually prevent. So we tried, and that's what actually they're selling more often. So unfortunately, the industry pick it up. So it make it easier for people to buy what is accepted to them. So that's actually make our lives easier in that sense. But I promise you, I see more drama from the parents or others for the children, and the children adapt very, very fast. And the few that they can't, we will send a letter saying that they cannot do it, but it's an exception from all the patients that I have. And remember, cystic fibrosis was the first disease, and I'm the director of the Cystic Fibrosis Center, is the first disease that actually used mask and stay 6 feet apart. So for them, there was not new, and they understood. And the children actually wear the mask. Obviously, they aren't going to ask me, okay, well, they were not 8 hours a day. Remember, in school, they are not 8 hours without with the mask. They're going to eat. They ask them to remove the mask. They're going to be outside. They're going to be the mask. So they're not constantly with the mask to the point that they cannot feel uncomfortable. Last year, many of them they wore it and they were fine with them. I think this is the, like Dr. Laufer already says, this is the only barrier that we have for less than 12 years old. And at this time, with the infectivity of this Delta, is the other barrier that we need.
Such a great point. And this is one of the things that I love about being a physician, and I think all of you, when we can share our experiences, the point about cystic fibrosis kids wearing masks for a long time, well before COVID, to not get sick. I think that right there is telling in itself. Let me, Dr. Laufer, I see you have your microphone, but let me move to Dr. Milla for a second, because I think a lot of families still this concern about CO2 rise or the oral motor, speech development, things like that. And particularly, we know that there's really, as Dr. Franco said, there's no good supportive evidence of the CO2 issue or the speech and language development. Tell us, though, what are some ways that families who are concerned about their children, either with speech and language issues not being seen by other children with a mask on, or just the mental wellness of starting a new school with a mask on their face? As a pediatrician, what's some advice that you and your colleagues are giving kids?
I'd like to answer that question by stages of development, right? So for the young ones, the preschoolers, the 2 to 4 year olds, those kids learn through play, right? So we know that. And so ways that parents can help them normalize the use of the mask is by using play. So if it's a paper mask, they can maybe, put some stickers on it, decorate it, play with the parents. If the parents are wearing it, that's a great way to introduce the concept of wearing a mask to them, because they see, okay, my parents are wearing it. That's what I'm supposed to do. They imitate behavior as well. So that's for the preschoolers. Then the school age children, those children learn through information. They like to know, why do I have to do this? What is the purpose of me wearing a mask? So teach them that wearing a mask is going to prevent them from spreading germs. It's not only going to protect them, but it's also going to protect others. They like to be helpful at that age. School age children like to help others. And so if you tell them you're going to be protecting your friends, you're going to be protecting your family, you're going to be protecting the community, they'll be more apt to want to do it. And then finally, the teenagers, you want to validate their feelings. You want to let them know that it is annoying to have to wear a mask. And sometimes it can be frustrating. Why are we still wearing a mask, 18 months in? But if you validate their feelings, and you let them know that it's part of their responsibility, not only to protect themselves, but also to protect others, then again, they're more apt to do it. Some of the things that I tell parents that they can do, especially now when school starts, because they're going to be going in and meeting their friends at school, maybe some that they haven't, met before. Maybe they can do like little buttons with, their picture. So, to remove the mask to show them their face. Other things that they can do is maybe do little Zoom meetings with a few colleagues, and they can, play without their mask. And that'll be a little bit of like a play date. And they'll be very excited to do that.
I love how you said that I have to teach Zoom meetings with their colleagues. Look what we've all been through over the last few years, right? I think Zoom play dates with their friends, but I love how you said that. So
it's fascinating that people say about the speech. Actually, the way you learn is also hearing, listening, and you're not going to be without the parents are not wearing the mask at home. So it's not limited into that. So there is no evidence so far, and they have not shown that evidence is that it will be a delay. And we don't even have enough right now evidence of any of this, because we haven't exposed enough these children to say this type of thing. Children adapt faster than adults. We are more fuzzy than children. They cry easier. I think probably will be better for us if we can cry, because it will make it a little easier. They move very fast. They know, and they move, and they adapt. We are the ones who stop the adaptation into them.
No, I think that's great. And as you said about the Zooms, I mean, I love that idea, especially for kids who are going to be in schools where all the children may be wearing masks, to set up some play dates online before, so the kids get to know and see each other. I think that's great advice you shared. Dr. Mestre, another big question. So we've been talking about masks and for kids in mask schools, but what about the parents who are concerned, whether it's daycare or the younger kids, where masks are really not even an option if you wanted your child to wear one? Lots of concern about kids in close proximity, even the older kids eating together and things like that in school. What are you telling parents and by all means the rest of the panel in these situations?
Yeah, what we got to do as a community is try to protect them as much as possible. Those are, as I love the way Dr. Laufer puts it, in terms of they have not had the privilege of having that opportunity to receive the vaccines. And as we see in the hospital, many times when we have those children under 12 that haven't had the opportunity, their family is infected. So what we recommend is for those parents that are with children that are younger than 12 that can't get the vaccine, is for them to get vaccinated. And if there are any siblings in the home, for them also to get vaccinated. And everybody's going to have to do their kind of risk benefit analysis. Every family is different, and we understand that. And we don't try to be dogmatic in terms of saying everybody has to follow the same recommendations. That family that has the immunosuppressed sibling or relative in the house may not be willing to take that risk that the child might get infected and bring home the COVID infection. We are seeing now that younger children are able to spread it better than we thought before, especially with the Delta variant. So again, that is a true risk. So if you have a member in the home that's immunosuppressed, it may be worthwhile keeping that child at home if possible. Again, thankfully, we see all these children that have these infections. 99% of them do not require hospitalization. The mortality rate is 0.008%. So you may ask me, well, why even get vaccinated if that's the case? Well, part of it is, number one, to protect the child. But even if they do get infected, they will do relatively well. But it's also to protect our community and to be able to protect those that may not be able to be protected themselves, so the children aren't spreading it to those vulnerable individuals. So in summary, basically having that conversation with your physician and doing the decision that is best based on your risks that you have within your own families.
I think that's a great point also you make about talking with your primary care doctor or your pediatrician. The pediatricians in the community have been absolutely amazing. And I think that's a great point to reach out and talk, because they're a tremendous resource as well for all the families.
I do want to give kudos to all our clinicians in our area and our political leaders that have. In Miami-Dade, we actually have the highest vaccination rate in all of Florida. And the same goes for many of our adolescents. We are at about 60% of our adolescents have received one dose of the vaccine, and about 40% are fully immunized. So kudos to all.
Yeah, no, South Florida has done well. Still room to go, but we're trying to protect our kids as best as possible. I'm gonna skip ahead. I had a question about sports and masks outside. I think you answered that, Dr. Franco. No need for masks when playing outside with sports. While we're sort of still talking about school and these scenarios, Dr. Laufer, we've heard lots of things about people wanting to have birthday parties, quinces, bar mitzvahs, and saying it's okay, everyone can come, no masks, because we're going to do rapid tests before. Shed some light on that for us.
Yeah, not every rapid test is the same. I mean, the test that we had today was a rapid test, but it was a PCR-based test. So that will detect most of the people infected. But the rapid test that you will get at the local pharmacy is an antigen test. And that test will probably identify many of the positive patients, but will miss many of the positive patients as well. So I do not think that it's a good idea just based on antigen tests to let a party go. If you do something like a PCR to every single person 48 hours, and then you add an antigen to that, and then you add open space before vaccine time.
Thank you. So
Actually, Dade County say that they're not doing antigen anymore by itself. You're going to do your test, they do the antigen and they do the PCR. They stop because of the same reason. There's a lot of false negatives. So if you are going to a place to get tested, they were going to do you both. In the past, they were doing only the antigen, not anymore.
yeah, so no rapid test for parties is not safe.
I would not do that.
So we have about 15 minutes left, and then we'll switch to some direct questions from the audience that can be submitted by the chat. And I know parents at home are looking forward to that as well. So I want to spend these last few minutes talking about what happens if either a parent's child gets exposed to someone with COVID or actually gets COVID themselves. So let me go to Dr. Milla. Can you talk about what symptoms we should expect? Child comes home, maybe they're sniffly, maybe they have a little cough. What symptoms are we seeing today, and how do they differ from regular childhood respiratory illnesses?
So some of the common symptoms that we see in kids infected with COVID-19 include headache, runny nose, cough, sore throat, fever. All of these, as you can see, are very common symptoms and non-specific. So they can really be seen with any upper respiratory infection, any other viral illness. Some other symptoms can include chills, nausea, vomiting, diarrhea. But the ones that are more specific to COVID would be new onset loss of smell, new onset loss of taste, chest pain, persistent cough. So those would be the ones that, but again, non-specific symptoms. They can be seen with any viral
is
syndrome.
The adage that sometimes we've heard, if there's snot, it's not COVID. True or not true?
No, not true.
Not true. Right. So
There's a difference actually with the Delta. The Delta actually shift from the other one was very clear. We didn't see any runny nose, anything like that. And this one actually shows at the time that RSV and other viral infections were coming back. So that's what it took a little bit off of all of us. But what the other interesting thing is that they know who had COVID and they were around that person. So many times they give us a clue in that sense. And other times they don't give you. And you see many kids have been tested several times. They come to see me and they said, "Doctor, I promise you have been tested 3 times and he's negative or she's negative." So because now we don't know. So we have to test, unfortunately.
Now, it is important though that the big difference that we're seeing among you compare influenza to COVID is that the first 5 or 6 days is the calm before the storm comes. It's almost look like when you are watching the hurricane coming on TV and you see nothing in your house, and then all of a sudden the symptoms start. So usually those who are gonna get very sick, they're gonna get sick a little bit later than the usual RSV or influenza.
And I think that's a great point. And maybe Dr. Mestre, you can talk about when should children get tested. So if someone has an exposure or if someone is symptomatic, what time point do you go? Do you run that afternoon if you found out, or do you wait a few days? And what tests specifically should families be seeking?
Sure. So going back to and alluding to what Dr. Milla was mentioning, one plea I would like to make to parents is if your child is sick in any form or any way, to please take that more seriously than we did 2 years ago. To please keep that child home and have that discussion with your pediatrician. As Dr. Milla and Dr. Laufer and Dr. Franco says, sometimes it's difficult to decipher whether these are symptoms secondary to COVID infection versus run-of-the-mill common cold. So always recommend speaking with your pediatrician. And if you are having those symptoms that have been going on for a couple of days, the ideal test is to do a PCR test in terms of determining whether there's infection or not.
And does oral make a difference? I know sometimes we parents think oral is more gentle for their children.
If the availability for oral has been shown to be just as sensitive, if it's available. Sometimes it's hard to find those centers that have the oral swabs to be done. In regards to the antigen tests, they could pick up if it's during an active disease process, but not as ideal as the COVID and the PCR test. And in regards to if you are exposed and you don't know if you had the infection or not, and you're not having any symptoms, we recommend not to go immediately to have the testing done. Typically, it's a period of between 3 to 5 days. Within one of the differences that we are seeing with the Delta variant is that you typically become symptomatic sooner as opposed to the variants that we saw at the beginning of the pandemic. To be safe, typically on the 5th day after the exposure to get tested. And if negative at that time, you can feel comfortable that you will not be infected.
So that's
but during those 5 days, we take care. We act as if we're positive. We responsibly do not expose other people.
Yeah, that's exactly what I wanted to touch base on, and maybe anyone on the panel can comment on this. So if you are exposed, the recommendation is not to get tested immediately after because it may not give an accurate result. To presume from a behavioral standpoint that you are positive, because we'd hate to see a child be back in school or an adult and then 3 or 4 days later get tested, although it would be unlikely they could spread it in those early days, but still for best practice. Talk about the quarantine protocols. I know a lot of discussions going on now with schools. So a child gets exposed to a classmate. What should happen to that child?
So it depends if the child is vaccinated or not. So let's assume they're not vaccinated. Typically that they're within 6 feet for a period of 15 minutes and cumulative throughout the day, whether they're wearing a mask or not, then at that point they would require a quarantine. Quarantine is typically within 10 days. There are some discussions in terms of for those that are vaccinated. So if that individual is vaccinated and is not having any symptoms, as Dr. Laufer mentioned, you need to be wearing a mask and assume the possibility that you have an infection and then get tested between 3 to 5 days. Again, if you develop symptoms, though, immediately get tested.
So if you have symptoms, as you said, get tested. If you get exposed and it's a known exposure, a meaningful exposure, it's 10 days quarantine and get tested a few days after, not right away.
Correct. Again, ideally at around 5 days.
Great. That's so helpful. If any of the other panelists want to add anything, now would be a great time. I'm going to say one more time to our viewers tuning in, at the end of the program, you see us not wearing masks. That's because we are all vaccinated and we're COVID tested with PCR tests specifically before the event this evening, and we'll be replacing our masks thereafter. I'm going to switch to my phone now. If anyone wants to make a comment, while I switch to my phone, they've set it up so that I can get the chats to my phone.
I'd like to add, if we have, about I was talking about tools that we have to minimize disease severity. If please do not start on steroids right away when you were exposed. Please, we've seen many patients who come and they start taking medications like prednisone or dexamethasone early on, and that is not a good idea. There is available now a treatment for those who are at high risk for progression to disease.
This is one of our first questions, so go for it.
Oh,
I see
really?
it on the list
Oh,
already.
Okay, so there is a medication now, or that medication started really a long time ago. We're on the second generation of medication, and it's called the monoclonal antibodies. And those are type of medications that you can use to prevent the person who had been infected from having severe disease. That medication is not available to every single person. In the case of pediatrics, has to be ages 12 years and over and 40 kilos or over who has certain risk factors. For example, morbid obesity, diabetes mellitus, sickle cell disease, immune deficiencies, severe asthma, not any type of asthma, or cystic fibrosis, cancer, or patients who have inflammatory bowel disease like Crohn's and ulcerative colitis and getting that type of treatment. And the importance about that medication is that it works when you are not that sick. If you want to get the medication day 7, 8, or 9, what I was telling you earlier, at that point, the effectiveness of the medication is not as good.
It's supposed to be in the first five days of the disease. So that's why we encourage people. For example, my patients who come and they're eligible for it and they haven't had the vaccine for X or Y reason, or even they had the vaccine and there's a breakthrough in the vaccine, I tell them you need to come immediately. In the 5 days, because after 5 days it's more difficult to get
But the take-home message for our families is healthy child gets COVID, you do not need to run to the emergency room for a rejection.
Right. So the mainstay of therapy for otherwise healthy children continues to be supportive care.
Perfect, thank you. Wow, so many questions on the list. Let me just share with everyone watching at home. This will be recorded and posted. I see lots of them that we discussed and perhaps folks turned in later regarding myocarditis, infertility in the vaccine, lots of things. So by all means, please, we'll share this online and you can go back and many of these have been answered. There's a question about the peak. Dr. Mestre, do we know when this is going to peak? Is it going to peak?
Yeah, I wish I knew the answer. And I would be going on every news station if I did. But what we're trying to see is in terms of what we saw in the UK with the Delta variant, it was a rapid onset peak and a rapid decline. And they're kind of going still through the decline at this time. And we're about 2 to 4 weeks behind what would the individuals in the UK are seeing. Although it's a little bit different. Obviously, it's a different environment, different vaccination rates, so it's difficult to predict the peak here. We've seen here where we're in that rise in the south, where other areas in the country haven't seen it yet. My prediction is that those areas will see it a little bit later than us, and we'll be on the downside of that. So I'm hoping we're at our peak now, and that we're getting over it, and we'll soon be on the decline. Obviously, with school going back, it's something we'll keep a close eye on. But at this time, nobody knows for sure when will be that peak.
And unfortunately, like in England, they did a lockdown when they saw that. The behavior changed immensely. We didn't. We continue our lives normal, and because we have available vaccines. That's the incredible part of it, is that we still have available. What I do see, thank God, in a way, you put it that way, is I'm seeing more families finally saying, okay, I'm going, and there's a whole family getting the vaccine, 4 or 5 of them at the same time.
I want to share a case that we had last week. It was a girl, 13 years of age, who came with severe pneumonia, spent 10 days in the hospital. And then when I do the history normally, I assume that they're going to tell me we are not vaccinated, we don't believe in the vaccine. And there were 6 people in the house. And she was the only person under the age of 18. And everyone was vaccinated by her. And when I asked the mother, why isn't she vaccinated? She told me, I don't know. And so when you talk to friends and you see that they decide not to get vaccinated, find out, believe it or not, some people who are eligible, they don't know that they are.
So she didn't know that the vaccine was available for adolescents under 18.
And she ended up for 10 days in the hospital. They're very sad.
Of education is one of the best tools we have in this disease.
I do want to mention for the audience, we do offer the vaccine at Nicklaus Children's, and we have it on Tuesdays and Thursdays from 7 a.m. to 7 p.m. and Saturdays from 9 a.m. to 2 p.m. Walk-ins are welcome. So we do offer it at Nicklaus Children's for children between 12 and 21 years of age.
How many have you done?
We've administered for those between 12 and 21, we've administered approximately 7,500 doses.
Wow, just at Nicklaus. I think we have time maybe for 3 or 4 more questions. Dr. Franco, let me ask you this one. Asthma, high risk for kids? Is a child who has regular pediatric asthma, should they be considered high risk? For Dr. Milla, from your experience as well?
I think the severe asthmatics is always a risk. That's the one that we are more on top of them. Fascinating enough, they do, when they had the disease, they're doing fairly well in the sense that they do respond to the treatment of asthma. We do see them in, for example, in telemedicine, and they actually do fairly well. Still, we are at concern, and severe asthmatics, if they are 12 years and above, we do use the Regeneron. We don't want to make sure that they are the ones that they can have in the issue. But the majority of the asthmatics that we have seen, they respond fairly well to the treatment. They respond different than the other ones. We use the steroids for a reason. And basically, and they do use the inhaled steroids more often because they're already on it. So the surprise for all of us is that even with that, they've done fairly well, the children with asthma, but we don't take risk for them.
And Dr. Milla or Dr. Franco, similar question about innocent heart murmurs or small PDAs, little holes that are occasionally in the heart. Those children at higher risk?
Not necessarily.
Great. Dr. Mestre, you touched on this before, but I see a bunch of questions all around the same theme. So maybe you can just retouch on it. Obviously, it's a question families want to know, whether it's lunchtime without a mask or nap time without a mask. What can we do?
Yeah, those are always going to be higher risk times when you're not wearing the mask. If there is the capabilities of doing activities outdoors, such as eating lunch, and you're doing it outdoors, being 6 feet apart, that's what is recommended. Obviously, not everybody has those capabilities, but that would be the ideal in terms of diminishing the risk of infections. Or if you are indoors, separate as well, in terms of making sure that those individuals aren't infected. And you also have to touch on, for those individuals that are vaccinated, say you have an older child that's 12, 13, and they may be vaccinated, you may ask, well, why do I have to wear a mask? What's the issue there? And we have seen indications that the viral counts within the nasopharynx may be just as high as those that are infected. Again, we're trying to determine whether those individuals can infect others as well. And while we're figuring that out, that's why we're making those recommendations that even vaccinated individuals within a classroom be wearing a mask as well.
And remember, the American Academy of Pediatrics thought very truly about this, about mask, about what we should do. And there's a panel of experts before they came up with this recommendation, because, this is the entity that actually make these kind of rules and regulations, or at least recommendations. The other thing that we need to have, very important, ventilation. Ventilation is very important, because you don't have any, that's one of the other issues. No, we should allow many times to open windows, and even though it's hot and humid, but it's better than being sick. So many times think about ventilation. Ventilation is the one who's going to make a difference, or could make a difference, because there is not concentrated in one particular area.
Great, thank you. I think we're going to go to one last question. Which is, what's the most significant reaction we've seen from the vaccine at Nicklaus, and what have we seen nationally in a child?
Sure. So the immediate reactions that we monitor are for any degree of what we call anaphylaxis. What Dr. Laufer had mentioned earlier is an allergic type reaction. We've seen 2 children that had some degree of a reaction, but those self-resolved after we evaluated them for a little bit longer period of time. Other than that, we saw no other immediate reactions on any of our other patients that received the vaccine. In terms of the other not longer term, but I've seen a few days after, as I mentioned before, in terms of the myocarditis, there have been reports of perhaps what we call Bell's palsy that's limited and self-resolves. Again, I wish I could tell you every vaccine's 100% safe and there is no side effects, but the minimal side effects that we see with the Pfizer and the Moderna and the Johnson & Johnson vaccines, those benefits that are provided for it way outweigh any of the small risks that there are.
Great, thank you so much. Well, I want to thank everyone, but before I thank the panelists, to wrap it up, I really want to thank Paul and all the efforts from the JCC. Of course, Karen Sepentwall from the JCC as well. You really did a tremendous job this evening helping facilitate and share this information. You've heard me mention education being one of the most important tools. And without the help that you put on, and of course the Alper, David Posnack, and Michael Ann Russell, JCCs, for being a part of this. This event wouldn't have happened. So we're all very thankful to you. Mayor Gelber, thank you for your involvement and participation in the evening tonight. To our Victor Center colleagues at Nicklaus Children's, Debbie Wasserman and Sherry Dabowski and Yolanda Perez, we're grateful for all of you for the work that went into this evening tonight. And of course, the Nicklaus team that helped put this on, from our communications folks and IT team, really was tremendous. Thank you. I want to thank the panelists, Dr. Mestre, Dr. Milla, Dr. Laufer, and Dr. Franco. Thank you. I know that this was really a very meaningful event to all of you to be able to participate, and I hope the community found it as well. There's no perfect or easy answers, and I know as parents and physicians, you try to give the best advice that we know, so we're grateful. I also want to thank all of our medical community who may be listening tonight, from all of the first line docs who are back again. We say it's like the fourth quarter of a game, that we don't know when the clock's going to run out. So thank you to you, to the community pediatricians, and everyone out there who's trying to make a difference. We appreciate all of you. So thank you so much, and good night.